Our case presentation is of a 35-year-old male, otherwise healthy, who sustained a left knee injury while snowboarding in Japan approximately 1 week prior to presentation. Interestingly, the patient developed a DVT in his left gastrocnemius vein that required IVC filter placement prior to surgery. On exam, his left knee was noted to have a mild effusion. There was no erythema or ecchymosis, and the patient was able to straight leg raise. He had active range of motion from 0 to 90 degrees, as well as a positive anterior and posterior drawer. He was noted to have a 2B Lachman and displayed laxity to valgus stress at both 30 degrees and 0 degrees. Operative radiographs were obtained, which demonstrated avulsion fractures of both medial and lateral tibial eminences, consistent with cruciate ligament injury. MRI imaging was obtained, which demonstrated injuries to the anterior cruciate ligament, posterior cruciate ligament, medial collateral ligament, as well as the medial meniscus. Planned reconstruction included a BTB allograft for the ACL, an Achilles allograft for the PCL, and an Achilles allograft for the MCL reconstruction.
Examination confirmed insufficiency of the MCL as well as ACL and PCL injury. Arthroscopy was performed, debridement and confirmation of both the ACL as well as the PCL tear. The remnant ACL and PCL are incised. Our attention is first towards developing the plane and the posterior aspect of the tibia. Once this is performed, the flip cutter guide is inserted. And this is drilled through the PCL insertion point on the tibia. 11mm flip cutter is utilized. The guide is used to protect the posterior soft tissue structures, and the flip cutter is leaned back to the anterior aspect of the tibia. Passing suture is placed after the tunnel is debrided. This is then brought out through the anterior portal. Femoral tunnel is then drilled. This is done in the anatomic insertion point for the anterior lateral bundle. And after this is drilled with 11mm reamer, this is done in antegrade fashion. The passing suture is placed and a Gore-Tex reamer is then also placed through the knee. Our attention is then turned towards the ACL reconstruction. A flip cutter guide is utilized here. And the flip cutter is drilled back to a depth of 25mm. The tibial tunnel is performed with standard antegrade reaming. And a 10mm reamer is utilized here. Graft selection would be an Achilles allograft for the PCL reconstruction and a bone patella tendon bone allograft for the ACL reconstruction. The Gore-Tex reamer is used to pass the soft tissue portion first of the PCL reconstruction, followed by the bony plug being fit and press fit into the femoral side. After screw fixation is performed here, our attention is then turned towards fixing the medial root avulsion. 2 number 2 fiber wire sin stitches are placed. The bone patella tendon bone allograft is then brought into the knee through the tibial tunnel. And then guided into the femoral tunnel with a probe. Notching is performed through the medial portal. This is then followed by insertion of the guide wire and then a 7x20mm metal interference screw. MCL graft prep is completed. This will be 18 millimeter long bone plug, the 20 millimeter long bone plug, that's 9 millimeters in diameter. The graft is sized at the bone plug portion to pass through easily through a 10 millimeter tunnel, and whip stitching is performed of the Achilles. Passing suture is placed and sizing is performed to make sure it passes through a 10 millimeter tunnel. Guy wire is inserted just proximal and posterior to the MCL and confirmed under image intensification to be in the correct area. This is then reamed with 10 millimeter reamer. Graft is placed, press fit, and then secured with a 7 by 20 millimeter screw. Our attention is then turned towards first fixing the PCL with the knee 90 degrees of flexion, followed by the ACL, and then the MCL on the tibial side with a tibial screw and washer. This is done with the knee in 20 degrees of flexion with a varus stress to the knee to take stress off the MCL. Final construct is seen here.
Postoperatively, the patient remained non-weight bearing in full extension for 6 weeks. At 6 weeks post-op, the patient was progressed to range of motion exercises. His weight bearing was advanced 20% of his body weight per week during postoperative weeks 6 to 10. At postoperative week 12, the patient began closed kinetic chain strength training as well as proprioceptive training. His long leg range of motion brace was discontinued after 10 weeks, and the patient was placed in a PCL functional brace for all activities. Postoperative imaging demonstrated appropriate implant and tunnel position.